Okay. We are Today we are trying to take up the topic that is nasopharyngeal angiofibroma. It has got. We'll try to cover etiology, pathogenesis, clinical features, and management aspects. Start. Today we are trying to cover the topic that is nasopharyngeal angiofibroma. So it is one of the benign conditions, and we'll try to look into every aspect that is including etiology, pathology, and clinical features, and the management aspects. Under the heading epidemiology, there are various reports on the incidence and prevalence of the disease has been mentioned. Different centers give their different rates of incidence. It is mentioned that in USA, the annual admission rate is 1 to 2 cases per 2000 admissions. But its prevalence in UK, the figure is 1 case per 15,000 admissions. Later on, angiofibroma is exclusively a disease in males. The occurrence in male is very rare, but at the same time, not a single case has been mentioned in the female population. But it has got its own peculiarity. But some people even deny the case of angiofibroma in female reported that is being taken as a not acceptable. That was the information as of incidence in only male gender. Right? The age range has been found to be between 7 and 19 years. Mean age of presentation is around 15 years. When the child or the person attains 20 years, usually progress is arrested or if not much of aggressive behavior. And it is under the heading pathology, we will look into the pathogenesis. Exact cause of the disease is not really known, but various theories have been put forth to explain its origin. Regards in 1938 suggested that the tumor arises from the periosteum of the nasopharyngeal wall. Sohn and Nefson in 1940 believed that inequalities in the growth of bones of the skull base result in hypertrophy of the periosteum of the nasopharynx, leading to formation of the tumor. So the skull base is basically basis sphenoid and the clavicle region of the occipital bone. Bench and Ewing in 1941 thought that a tumor arises from the embryonic cartilage present between the basic occiput and basis sphenoid. I just happened to let inform just now. But Brunner in 1942 suggested an origin from the conjoined pharyngobasilar and buccopharyngeal fascia. Osborne in 1959 considered the possibility of swelling being a hematoma or fetal erectile tissue subjected to the hormonal effect. So the hematoma means that it is not a tumor, but it is away from normal structure. And Zirgis and Fams in 1973 suggested that the possibility of the paraganglioma being a forerunner of the angiofibroma. These are sites of origin. In the past, it was assumed that the vault of the nasopharynx is the site of the origin. Some others considered that choana to be the site of the origin. Nowadays, the spinopalatine foramen is being considered the site of the origin, which is being accepted widely, and this explains the bilobar nature of the large tumors. The central tract occupies the spinopalatine foramen, that is in the lateral wall of the nose, behind the attachment of the middle turbinate. So one of the lobes occupies the nasopharynx, and the other lobe extends into the pterygopalatine fossa. If it further spreads laterally, it will go to the infratemporal fossa. The nasopharyngeal portion grows medially beneath the mucous membrane of the nasopharynx, displacing it downwards. Eventually, it fills the entire postnasal space. What are the extension possible? Origin, we already know it, and later on it is being mentioned as the bilobe. So one is in nasal cavity, other is in the your spinoparaton other side, ergoparatal fossa, and also infratemporal fossa. So extensions, when it goes into the nasal cavities, they gain secondary attachment, thereby they will draw the blood from the regional arteries. It may displace the nasal septum or other structures. Septum usually will be pushed to other side and it may erode and invade the anterior face of the spinal. The erosion will be taken by means of the pressure erosion. And growth in the lateral direction may involve the ergopalatal fossa. Later on, after filling it, this process may cause further bowing of the posterior wall of the maxillary antrum. Thereby, it is called Osler-Muller sign. Eventually, it will reach the infratemporal fossa. So there will be pressure on the posterior wall of the maxillary sinus. This is one of the important signs we interpret while taking up the CT scan in axial sections. When it spreads anterolaterally, it will spread out to the orbit through supraorbital and infraorbital fissures and produces proptosis and also frog face deformity. Superior extension will lead to intracranial spread. So we categorize this intracranial extension under stage 4. The main blood supply of the angioma comes from the maxillary artery, which is the terminal branch of the external territory. The other being superficial temporal artery. So we are nowhere related to it. Our main concern is the maxillary artery. So other arteries like ascending pharyngeal, medial, and internal carotid may contribute rarely for its vascularity. So very rarely, vertebral artery may also contribute to give blood supply to it. All these things can be identified by going for your digital subtraction angiography. I use the same thing for embolization, which is being taken as a pre-operative measure for excision of the tube. When I come to the investigation aspects, we will deal with it. What is the macroscopic appearance? Grossly, angiofibroma, its name itself shows it has to be having a pinkish color or it's not red color. So because it is filled with the angiomatous tissue of cavernous nature and filled with blood spaces. Definitely we can imagine it is having a firm, spongy and lobulated swelling. Color varies from pink to white depending on the vascular component. In the case of younger age group, the vascular component dominates the fibrous component. So that's why it is being mentioned as a angiofibroma. As the age advances, the growth will be reduced, not with aggressive growth. Ultimately, fibrous element will be more compared to angiomatous element. Then sometimes it is being mentioned as a fibroangioma. So while operating, we can notice the difference. If it is fibroangioma, the amount of the bleed is not much when compared to angiofibroma, where it bleeds more when compared to fibroangioma. On cut sections, the tumor shows a reticulated whorl or spongy appearance and identify and when keep in mind it doesn't have a capsule. So in the early lesions, vascular component is more. I just happen to tell you now. And as the age advances, the collagen component predominates in the lesion. That it is being mentioned as a fibroangioma. This is a clinical specimen, whereby to my left side, it is a total specimen, and after on right side, it is being cut. Thereby, you can see fleshy mass. Thereby, you can see it is having a some sort of pinkish color. Thereby, it is not a cystic. It is nothing but a tough, leathery uh, skin cover. Later on, deep down is your fleshy mass. What is the microscopic appearance? Microscopically, the tumor contains vascular spaces varying sizes and shape in a pivotal trauma. Muscular tissue is absent. That is one of the important things you have to keep in mind. So when there is no muscular tissue, that is smooth muscles, definitely doesn't have the capacity to contract. When it is not there, it will get in, when it gets injured, the tumor will bleed because there is no contractile tissue. So bleeding doesn't stop very easily. Hence, the biopsy of the tumor, if at all suspected, should not be planned. So definitely, you have to think of going for other mode of um, other mode of identification, but never attempt to go for a biopsy of this situation. And at the same time, we must be gentle in handling while examining. So when you suspect the angiofibroma, please don't try to go for a biopsy because of the fear of uncontrollable bleeding because it doesn't have the contractile tissue that is your smooth muscles. This is the microscopic picture showing vascular spaces and also the fibrous tissue. These are the other cut sections informing the high power presence of the cavernous spaces and also the other fibrous tissue. What are the clinical features? The cardinal symptoms of angiofibroma are nasal obstruction depending on the size of the tumor and also the extent of the involvement of the mass. And also the prime complaint is epistaxis. Sometimes epistaxis in a male individual, if it is quite voluminous, must be considered as a mesothelioma in a male individuals, especially in the growing group up to 20-25 years. So definitely never venture to take that recurrent epistaxis of high volume in a male. You have to think in terms of mesothelioma as the first possibility. So later on, your duty is to investigate thoroughly and rule out if it is not there, confirm if it is there. And level of the management is excision. In the early stages, easy to remove the tumor in total. As the age advances, when it increases in size, when it extends to the infratemporal fossa, or pterygoparietal fossa, or into the orbit, or into the sphenoid sinuses, it is really difficult. You have to do a better planning, and sometimes you need to go for a we call it as a embolization, prevent blood loss. And there are situations where we used to keep blood units ready while operating also. So that is the amount of the scare we get. Earlier days, now we are at a good hemostatic procedures like coagulation and bipolar cautery, we are in a position to take up the case with minimum blood loss. So nowadays, we are not really doing blood transfusions, and embolization is one of these measures. Second thing is the workhorse is your coagulation. And go for a devascularization, remove the tumor in toto, thereby a good excision with a minimal possibility of the recurrences has been achieved. We will be doing either with endoscope or combined with routine open excision. So when it is limited, we go with endoscopic excision. When it is extensively seen, we have to go with a combined procedure, probably. If it is extensive intratemporal fossa or some sort of unaccessible areas, we are going for a combined approach. So nasal obstruction causes strength of regressions and sepsis of the nose, and paralysis sinuses also gets affected, and it is possible to have a associated sinusitis because of that volume and occupation. Presence of the tumor in the olfactory area. You may get a hyposmia and anosmia also possible. It is because of its location in the olfactory cleft. It is possible, but no other it doesn't allow the smell sensation is not possible because of the obstruction element. And next comes is bleeding for nose. It's a very characteristic of angiofibroma. It may vary from occasional show to life-threatening torrential bleeding. So chronic intermittent bleeding leads to anemia. That is one of the blood loss effect. It is not seen in females, only seen in male genders. If the mass is big enough, it may press down the soft palate and speech qualities also gets affected. You may get some sort of analalia that is being mentioned. Blockage of the sticker tube when it extension into nasopharynx. can lead to conductive deafness and ataxia. Involvement of the orbit may cause paralysis and failing or if not reduced vision. It will be giving an appearance called frog face deformity. Later on examination, anti-rhinoscopy is one of the mandatory things which show a reddish mass with purulent secretion secondary to blockage of the ostia of the sinuses. We see it is a mass between middle turbinate and septum, or if it results sinusitis, we may see purulent material in middle meters. As the septum may be pushed to opposite side by means of the increase in size in some cases. Posterior endoscopy shows a pinkish or red mass, regarded as a wild appearance, regarded as a red pink appearance, filling the nasopharynx. If the infratemporal region is also affected, you may see fullness of the cheek. Swelling of the temple may be seen. Sometimes it may give rise to trismus, and bulging of the parotid gland may also be seen depending on its location and its extension. This is the classical endoscopic view of the nasal cavity. In the case of angiofibroma, you can see the black arrow showing the nasopharyngeal angiofibroma. It is nearly reaching the coela, and the line of the attachment, the organ probably in this case is behind the middle turbinate. What we are seeing is the inferior turbinate. The mass is trying to expand down to the floor of the nasal cavity. Angiofibroma of the nasopharynx is also to be investigated with MRI. It definitely shows the total involvement. Definitely, it shows some sort of extension to the intracranial area, which is sort of usually pressure erosion's result. Definitely, it is trying to go to the intracranial, but it doesn't erode the dura. There is no. It enters the cavity, but it pushes the dura. It doesn't erode the dura. And angiofibroma of the nasal cavity is also assessed by axial sections. Thereby, we can know the limit of the extension medially toward the nasal cavity, and that means your ethmoid sinuses and sphenoid sinus laterally into the infratemporal fossa after crossing the pterygoparietal fossa. So, this is the one of the investigations needed to identify the three-dimensional expansion of the tumor. Thereby, we should have a better preparation to have the complete excision as a goal. Thereby, we can prevent the recurrence of the tumor. So, with this all armamentarium, we can give a good clearance. Recurrence is coming down to nearly satisfactory. No recurrence. Earlier days, we used to see a lot of recurrences because of the inaccessible areas. Now we got each and every aspect of involvement, including pterygoparietal fossa, and also pterygoid, what about Vidian canal, and all aspects. Sphenoid sinus can be easily identified. It acts like a roadmap to deal the case accordingly. The goal is complete clearance, whereby recurrences can be minimized or if not made zero. Angiofibroma of uh, the individual showing the extension to the pterygoparietal fossa. So thereby, you can even see here, this is the pterygoparietal fossa, this one, right? And we can see the extension to the nose, and it is going toward the infratemporal fossa. So this is the bilobe tumor already been mentioned. One into the nasal cavity, other is in the pterygoparietal fossa, expansion into the infratemporal fossa. This is the complete information in the axial view of the medial extension and lateral extension of the tube. We already seen sagittal sections, intracranial extension is identified. And this is one more thing. You can even see pterygoparietal fossa extension, and thereby this is your temporal lobe, that is middle cranial fossa. This is pterygoparietal fossa. This is your infratemporal fossa, that is below the temporal lobe. So it is already nasal extension. This is this is your pterygoparietal fossa, and this is your infratemporal fossa. So definitely almost gone to the level of inflammatory muscle. Clinically, you may see fullness of the cheek. Very rarely we will see the trismus. This is the, again, you can see one more picture. You are able to see extension to the sphenoid cells. These are the appearance in the axial. This is your coronal cuts. This is the one more cut. Definitely, it is showing the disease on left side. You can see dumbbell shaped tumor. This is your point of origin, that is sphenoid foramen, and immediately it extends into the nasal cavity, and laterally it extends into the lymphatic. Thereby, we can have a complete evaluation and an idea about the tumor extension. You can go for various approaches. Thereby, the goal to achieve is complete clearance of the disease. This is the, again, one more cut. We are showing the extension into the eye. This is on left side, this is on other side. Definitely, you are able to see extension to the eye, displacing the periorbital, but at the same time, it may be extension to the inferior orbital fissure and also superior orbital fissure. Thereby, you can get a displacement of the eye, thereby leading to proptosis, diplopia, etc. This again, so many pictures are really forming a lot of extensions. This again an intracranial extension, right? Uh, this is the section showing the intracranial extension, so thereby we can have a better understanding of its extensions, and thereby we can think of our limits before giving a rosy picture to the individual. Of course, this sort of extensions have been tried by Sapandara. This is the one cut mentioning about extension intracranially, but there is a displacement of dura. It doesn't erode the dura. These are the indications for radiation in these sort of cases where complete clearance is not possible in these situations. We are not trying to do craniofacial dissections in many or every case. We may use radiation therapy to reduce the further spread and increasing the fibrosis. MRI clearly shows extension of the tumor into the surrounding areas, and also there are about intracranial extensions. Earlier I told you the vascularity of the tumor can be assessed by carotid angiogram with digital subtraction angiogram, that is subtraction technique, will show vascular supply of the tumor. What are the feeding vessels? I just happened to tell you the major supply is basically maxillary carotid, the terminal branch being your sphenoid artery, which itself is a branch of maxillary artery, which is final division of your external carotid. And also I told about ascending pharyngeal, and also occasionally it draws blood from the internal carotid also. Very rarely it gets from the vertebral artery. It will show vascular blush in the postnasal space and adjuvant areas. I will show that pictures shortly. This is the one. This is a carotid angiogram mentioned with external carotid, and it shows tumor blush. We use embolization like your gel form and all sort of aspects, whereby you can get a sort of blockage, whereby tumor blush is reduced. This is one more carotid subtraction angiogram, digital subtraction angiogram actually. You could see the carotid system and also the feeder, that is sphenoid artery, and thereby you can see the tumor blush. Differential diagnosis has to be kept in mind. Angiofibroma has to be differentiated from antropical polyp. Usually, you have to think it as an immediate next possibility, and especially in group above 12 years. In the case of children, you have to think of adenoid mass also, but in the case of adenoids, you don't really get a bleeding purpose, and snoring and all features are common, but you have to keep in mind children. But easily clinically can be distinguishable from one from other, and X-ray lateral view will tell about intracanal polyp to be distinguished from adenoid mass, and also tumor of the post nasal space, and also carcinoma has to be kept in. Tumors mean majority of the time are benign tumors of the usually we get gliomas and other things. So what is the treatment available? The surgical treatment is the main line of treatment, a mainstay of the treatment, but preoperative treatment with hormones and external beam radiation will promote the collagen formation and reduce vascularity. Earlier I told you when there is intracranial extension and it is not really resectable, in that situation you can add your radiation as an entity to after doing your surgical excision. So thereby it will promote fibrosis, it will further reduce the spread of the tumor. The blood loss for the surgery is minimized. Testosterone also or in combination with estrogens will increase the maturation of the collagen and reduces the vascularity. Ionizing radiation will cause shrinkage of the tumor and also hardens it so that the bleeding is minimal during surgery. Radiotherapy is also given in inoperable lesions like those with intracranial extensions, but many clinicians are hesitant to use radiation as a modality of the management as the mass in young adults can lead us to carcinogenesis. So we really hesitate to use radiation as one of the modality of management. I just happen to tell you, inoperable intracranial extensions can be managed with low dose radiation. Preoperative embolization is one of the things we used to use earlier times. It also reduces bleeding during surgery. But soon after doing your embolization, the case must be taken very short time. That means 48 to 72 hours you must take up. Otherwise, again, collaterals form. That's the reason. Just plan for excision. For that, do your so-called angiogram, carotid angiogram, and later on immediately do for embolization. But don't delay your surgery after embolizing the tumor. The tumor confined nasopharynx is removed by various approaches available. After that, depending on the extension, various approaches have been accepted. Probably the combined approaches also been so-called planned. And the goal of the treatment is surgical excision in toto to minimize the recurrence. The tumor confined to the nasopharynx usually removed by transparent approach. It is being mentioned as the Wilson's approach. The surface of the tumor uh, should not be branched. I think otherwise there will be severe bleeding. So usually we will go for a coagulation, whereby the devascularization can be easily achieved. The amount of the blood loss can be minimized. It is nothing but a match winner, we call it. Right? For tumors spreading to the pterygopatal fossa, the combined transparent approach but also cardiac approach through the maxillary antrum is also being planned or is adopted. So thereby you can go into the pterygopatal fossa by removing the posterior wall of the maxillary sinus. We go into the pterygopatal fossa, identify your maxillary artery, clamp it, thereby you can remove the tumor after clamping the uh, maxillary artery. And this is the, for your information, angiofibroma, preoperative embolization. You could see the network of the blood vessels, which are the feeders to the tumor. And the complications can occur after surgery. There may be peritone fistula, may result when we go to the transparator approach. Usually if it is small, we leave it like that. If it is big, we can try to go with a flaps. That is, peritone flap can be used, but try to get a good closure, and thereby we can minimize the fistulas. And also slight atrophian of the lower eyelid and possible when you go for a Weber Ferguson sensation, etc. Anesthesia of the cheek and crusting of the nose may occur if we go for Weber Ferguson incision, and thereby in course of time patient will settle with medical treatment with methyl cellulose eye drops, and the anesthesia of the maxillary nerve can be temporary, or if not it will be managed by neurotropic vitamins. Rarely recurrence of the tumor may occur. So thereby, in the beginning itself, I told you what is the plan. Investigate thoroughly, identify the situation talks of thing. This completes the topic with a good understanding. And before that, you should know what are the likely complications. Don't take it as a simple case like endocrine polyp, but also adenoids. Identify the case with the proper clinical information. Evaluate, examine, think of seriousness of the problem. But it is being mentioned as a mesocardial angiography. It is benign to label, but it behaves like aggressive, apparently benign, but clinically malignant has been mentioned while managing the case. You have to be very proper in planning, know the extent of the disease, and your goal is to complete excision of the tumor by means of various approaches, stance, paradigm, Weber Ferguson's, all aspects has to become combined approaches. Your goal is to complete the excision, and if intracranial radius happen to tell you, add your radiation to increase the fibrosis to minimize the recurrence. That ends the topic. Thank you.